Bismillahir Rahmanir Rahim. Qalu subhanaka la ilma lana illa ma 'allamtana innaka antal alimul hakim. We started water and electrolyte balance, and then we discussed the basis of distribution of water and how does the body keep on different compartments of the body. And then we discussed how much fluid should be given to the patient and what type of fluid should be given. Before I go to the medical diseases and the choice of fluids, so very important electrolyte, which is sodium, this is the main contributor towards the osmolality or osmolarity. I thought we should go quickly through it, then I'll discuss different diseases and how to choose the fluids and how much should be given. Now, by definition, hypernatremia is if the sodium level is greater than 145 millimoles per liter. And clinical presentation is sodium 158 to 160 millimole per liter. So, if it increases up to that, it could be of acute onset or it could be of a chronic onset, because the management depends on its onset duration. There are three causes of hypernatremia. One is associated with hypovolemia, then a set of causes which is associated with hypervolemia, and then there are causes which are associated with euvolemia. And as far as the associated with hypovolemia and dehydration, now I'll tell you the basic principle is all the secretions in the body, they have got sodium level less than that of plasma. It doesn't matter how much fluid you lose from any routes, whether in the gastrointestinal secretions or from the dermal loss or through respiration, they have got sodium level less than that of plasma. All the secretions in the body, they have got potassium level higher than that of plasma. All these secretions. So it means the body tends to go into hypokalemia very quickly, and hyponatremia is very rare. Hyponatremia is induced only if there is sodium loss and you replace it by the low sodium solution. So it's the choice of solution which takes the person into hyponatremic condition. Now, this dermal loss from the skin, gastrointestinal loss, urine loss, and post-obstruction loss, and hyperosmolar non-ketotic coma. Now there will be predominant water loss as compared to sodium. It means sodium will be retained in the body and the water will be lost. The person goes into hypernatremia. Then there are causes associated with hypervolemia. As usual, iatrogenic. If we can't understand anything, we always say iatrogenic, or hyperaldosteronism, or excess salt ingestion. You go on taking too much salt. Then there are causes associated with the euvolemia, like diabetes insipidus, hypodipsia, fever, hyperventilation, and patient on mechanical ventilation. If you don't give adequate fluid, you can take the person into hypernatremia also. Now, presentation. As the sodium level is high, it means the osmolality outside the cell is high as compared to osmolality inside the cell. It means the water starts coming out of the cell. When the water starts coming out of the cell, water starts coming out of the brain cells. When the water starts coming out of the brain cell, it means person will be confused first. Then patient will be sleeping, and then patient goes into coma. Then the patient dies. This is a typical picture of hyperosmolality. If you see any person who is confused, who is going into coma, then goes into coma, it means you always do send the blood for electrolytes. Might be hypernatremic. If the patient is hyponatremic, if the sodium level is less, it means the osmolality outside the cell is less as compared to the osmolality inside the cell. It means the water starts going inside the cell. So cells become swollen. So cells of the brain will be swollen. When the cells of brain is swollen, the person is awake, the person will complain of having a headache, first thing. Then the person will be confused. Then the person starts convulsing because the distance of the mitochondria and the cell wall is increased. The required amount of oxygen in the required time cannot reach the mitochondria. And it is always lack of oxygen in the mitochondria which causes convulsions. Sometimes you are giving less oxygen, sometimes it's taking longer time for the oxygen to reach, and sometimes the brain cell requires more oxygen than the normal, as in epilepsy. Whenever you see a person convulsing, put the mask of oxygen on the face, because you will have to give oxygen to the mitochondria. Then if you don't treat them, convulsions, then the patient goes into coma, then patient dies. So these are two presentations, hypernatremia and hyponatremia. And once you see the patient, and you can never forget it, and immediately from the clinical history, you can make up in your mind whether the patient is hypernatremic or hyponatremic. Or on the other side, if you have got a level, while sitting in your office, you can assess what will be the condition of the patient, at what stage the patient is, and what is the clinical presentation of the patient also. You are sitting as a consultant or as a head nurse, and you can imagine, you can make the picture of the patient. The management, the objective of management is to diagnose and treat the underlying cause, and the immediate management is to correct the hypertonicity or hypertonicity or high sodium level. We'll have to bring it down to prevent the manifestation of hypernatremia. At the same time, try to find what are the causes. Now, initial measurement is you have to look at the hydration status of the patient. Then consider the causes which I have just mentioned. Then if the causes are unclear, you send the urine for osmolality and send the urine for sodium level also. The people hardly do this. They just go on giving the fluids and start treating. But it's very important parameter. Look at the urine osmolality and look at the urine sodium concentration. Now, correction of hypernatremia is if rapid development in hours. If the patient develops hypernatremia very fast, then the rapid correction should be done. It means reduce 1 millimole of sodium per liter per hour. This is a regime we always follow in ICU. 1 millimole of sodium per liter per hour is reduction. It's the quickest way. If slow development, that's in days, you do the slow correction. That target is 10 millimole per liter per day. Not per hour, per day, 10 millimole per liter per day. Then only hypotonic fluid should be given. Because if you give hypertonic, that will increase the osmolarity. Now, hypotonic fluid should be given. Then, where hypertonic sodium gained with overload, use diuretics plus 5% dextrose. That we'll discuss later on. Fluid requirement and water deficit. You look at the patient, how much patient needs water. And then required sodium fall, how much sodium we want to reduce, then which fluid you are going to give, and at what rate the fluid you should give to correct this hypernatremia. The same principle as for the fluid therapy. You first of all look at how much fluid is required, then you look at how much sodium you want to reduce it, then you look at what is the appropriate fluid you are going to give to the patient, and at what rate it should be given. Rate is very important also. Sometimes it happens that if the rate has become slow, some of the people who are looking after the patient, they go and they start very fast, that to compensate the deficiency. This is very wrong. You assess it at what rate the fluid should be given in the beginning and keep it on the same rate. That's why infusion pumps has been introduced. You put them on an infusion pump and let it go. It will go on the same rate. Then recheck the electrolytes frequently, because you are correcting the electrolyte. So you should recheck it at least twice a day, sodium level. If not 8 hourly, at least 12 hourly. Now, how to drop the sodium? 1 millimole per liter per hour. Total body water into 60% is the water. Total body weight. You calculate total body weight and multiply with 60, divide by 100. That is, for example, if this person is of 70 kilogram, or uska 60% will be 42 liters is the water. This is a tremendous amount of water. You got only 28 kilogram is the bones and muscles. Rest is water. Then extracellular fluid is 1/3 of the total. So 42 liters, 1/3 will be 14 liters. Because when we plan to correct the sodium, we plan to correct extracellular fluid. Because predominantly sodium is outside the cell. Our objective is to bring the sodium level lower in the extracellular compartment. It means intravascular and interstitial compartment. Now the excess sodium in the extracellular compartment will be 14 liters of water. And if you say the sodium level has gone up to 160, so normal should be 140. So 160 minus 140, it means every liter of fluid has got 20 millimolar sodium higher. Now you have got 14 liters of water in the extracellular compartment, 14 into 20. It means the total excess of sodium is 280 millimole. Is that clear? It's very simple. You calculate total amount of sodium which is excess in the extracellular compartment is 40 liter water into per liter 20 millimole. That becomes out to be 280 millimoles of sodium. This we have to reduce. Now, as we have calculated all these things, so total amount of fluid which is required to lower the sodium is 280 millimoles. You want to reduce it, and you've got 140 level should be target. 280 divided by 140, it means you require to give 2 liters of clear fluid to this patient. Is it clear? Because 280 is the total excess, but we want to bring to level of 140 per liter. So it means you require 2 liters of sodium-free fluid to bring it to normal. And now rate is 1 millimole per liter per hour. The total amount of water, extracellular water, is 14 liters. So it means every hour you will be reducing 14 millimole per hour. So if you divide this, total required to lower is 280 millimole divided by 14, it means it will be 24 hours. For every hour you have to drop the 20 millimole, and total target is 280 millimole. 280 millimole divided by 14, so that comes out to be 20 hours. It means you give this 2 liters of fluid in 20 hours. 2 liters divided by 20 hours means you will give 100 ml per hour. So very simple. You calculate the total amount of excess, and you calculate what is your target. So 140, that will give you liters of fluid to be given. Then you have got the 280 millimoles total, and you want to bring lower it to 14 millimole every hour, so it comes out to be 20 hours. So 2 liters you have to give in 20 hours. So it means for every hour you will have to give the fluid 100 millimole per hour. That will lower the sodium from 160 to 140 in 20 hours. So this is one of the regimes, fastest regime. Because if you go faster than this, it will quickly lower your osmolality outside the cell. Then quickly, when you lower the osmolality, the inside the cell is still high, so the water starts going inside the cell. That's why when we treat the ketoacidosis or we treat this hyperglycemia, we don't correct it very fast. Otherwise, we give large amount of insulin, because this glucose outside the cell is very high. If you measure in millimoles, for example, is 900 millimole. 900 milligrams of sodium glucose is high. So if you reduce it very quickly, it will lower the osmolality outside the cell, and the water starts going inside the cell. Patient will start convulsing. Patient goes into coma. So that's why it should be corrected very slowly, so that there should not be any other side effects of this correction. We go to next topic, which is fluid therapy in diseases. Now, if the patient comes with a hypovolemic shock, or the patient has got diarrhea, or the patient is vomiting, or the patient has got gastroenteritis, or patient is in respiratory failure, patient is in hepatic failure, patient is in renal failure, patient is in heart failure, and patient has a stroke or other brain insults, our patient has got burns, our patient is in sepsis, patient is pre-eclamptic or eclamptic, and
patient post-operatively goes to for fluid therapy. So there is a little bit difference in every disease, that
everybody should know it,
that what type of fluid should be given, at what rate the fluid should be given to each patient.
So let's start with hypovolemic shock. If the patient has got hypovolemia, you should be able to assess how much is the dehydration. If it is a mild dehydration, it means the patient has got 5% of dehydration. It means he has got about 3 liters of fluid less in the body. Then the second category is moderate dehydration, 5 to 10% dehydration. It means he is a deficient of 5 liters. Then third category is severe dehydration. If they are lost more than 10 to 15%, it means they are deficient of 8 liters. And accordingly, these three deficiencies should be filled in according to the basic principle. If the fluid has been lost from the vessel, first of all, fill the vessel first. Then fill the interstitial compartment. Then you fill the intercellular compartment. Our objective is to fill the body from inside out. Vessel has to be filled in any case, because it is the vessel which takes the oxygen and nutrition to deliver to the interstitial compartment and subsequently to intercellular compartment, and subsequently end station is in the mitochondria, because oxygen and nutrition is required in the mitochondria to have aerobic metabolism. If there is no oxygen reaches there, it means there will be anaerobic metabolism that will take the person into metabolic acidosis. Now, fluid in diarrhea. Now, the person is having diarrhea only, no vomiting. So, patient is losing potassium, they go into hypokalemia. Patient is losing chloride, they go into, the patient is losing sodium, they go into hypernatremia. And the patient goes into hyperchloremia also, they are not losing chlorides with the diarrhea. So, patient goes into metabolic acidosis. When the patient goes into metabolic acidosis, if it is not severe diarrhea, you give ORS to the person, that can correct it. If it is a little bit more, you give Ringolect to these patients. Ringolect because this lactate, provided your liver function is normal. If the liver function is normal, then lactate is converted into bicarbonate. Now this bicarbonate will neutralize the acidity which has been produced because of diarrhea. And when the acidity is corrected, so then if you treat only acidity, patient is already hypokalemic, then the further potassium goes inside the cell, patient further goes into hypokalemia. So these patients has to be treated, their acidity as well as the potassium has to be treated at the same time. Once you are neutralizing the acidity, you should start potassium also with it, so that patient does not go further into hypokalemia. If he further goes into hypokalemia, the potassium is a muscle relaxant also, whether it is hypokalemia or hyperkalemia in any case. So patient starts hypoventilation, goes into hypoxia and other things. Then if there is very severe acidosis, so severe hypokalemia, you attack both ways. You correct the acidosis by giving the Ringolect solution, and that will correct the deficiency of water also. At the same time, you start giving potassium also, because the person does not go into hypokalemia further. Now, if the patient is vomiting, very interesting. The child with hypertrophic, if the person is vomiting, or you put the nasogastric tube in and you are aspirating, you think you are taking out the poisonous material out of the stomach. No, you are losing a lot of water. You are losing water, you are losing sodium, you are losing potassium, you are losing chloride, and you are losing acid also. That takes the person into hypovolemia because you are losing water. And that takes the person into hypokalemic, hyponatremic, hypoglycemic, metabolic alkalosis. This is a very serious thing. When the patient is vomiting, or you have got a nasogastric tube in and you are sucking it, आप समझते हैं कि you are taking the dirty material out, but it's not dirty material, it's very useful material also. Now, this person who has been vomiting has got low sodium, low potassium, low chloride, and is a metabolic alcoholic. The same plasma goes to glomerulus, and it passes through the glomerulus. And the filtrate, which is in the proximal tubule, has got low sodium, no chloride, and low potassium and low magnesium. So here in the proximal tubule, sodium is reabsorbed along with the water coupled with chloride. So as the chloride is less, the sodium will not be reabsorbed there. So it means the bulk of water will not be reabsorbed there. So it means more than normal quantity of sodium and water will go to distal tubule. When it goes to distal tubule, there is more sodium available to be exchanged with hydrogen ion and potassium. So it means the body further goes into hypokalemia, further goes into alkalosis. So it means the culprit is chloride. So when you start looking at this patient is metabolic alkalotic and hypokalemic and hypochloremic, give them saline solution, not a ligurate. Give them saline solution. Saline solution has got a chloride. How much is the chloride with the saline solution? 1 gram is the sodium, 154 millimole per liter. So when the chloride is corrected, automatically in the filtrate in the proximal tubule, sodium will be reabsorbed and water will be reabsorbed, and it will start correcting other things automatically. Then you start potassium correction. If you don't correct the chloride and start using potassium, it is useless because they will be losing again in the distal tubule. It's very interesting. So when you start your saline solution, at the same time then you start giving potassium also. As far as the hyponatremia is done, patient never goes into hyponatremia with excess secretion because sodium level in all the secretion is less than that of plasma. So it is always because of your bad policy to give the wrong solution. You start giving 5% extra water, you start giving parabrate, you got less chloride. So you will never be able to correct it. So give them saline. If the person is vomiting, the choice of fluid is 0.9% saline. Correct other electrolytes as soon as you start with the fluid with potassium. If you start correcting potassium without correcting the chloride, you will never ever be able to correct the whole thing. It is a hypochloremic, hypokalemic, hypomagnesemia, hypovolemic metabolic acidosis. If you look at the ABGs, immediately you will find out what is happening to the patient. So the culprit is chloride in this. But there is combined vomiting and diarrhea. Gastroenteritis is so you do the serial ABGs and do the serum electrolytes, and accordingly then you choose the fluids. It can be a mixed picture because with the diarrhea you go into metabolic acidosis, with the vomiting you go into metabolic acidosis. So according to the electrolytes and ABG, then you plan your therapy. Respiratory failure. If the patient is in respiratory failure, you have to give fluid. Now, avoid high concentrated glucose because what is the end result of glucose? When the glucose goes into mitochondria, it is converted into carbon dioxide and water, CO2. If the person is breathing spontaneously and is in respiratory failure, there is more production of carbon dioxide. The person further goes into hypernatremia. So you will make the condition worse. Try to avoid glucose in those patients who are in respiratory failure and they are breathing spontaneously, they are not on ventilator. Once they are on ventilator, it doesn't matter. You can adjust the rate and tidal volume and you can wash out the carbon dioxide. If on IPV, volume replacement, not according to CP. Once the patient goes on ventilator, the central venous pressure catheter does not give you the correct status of intravascular compartment. The only way you can do it in advanced intensive care unit that you this pressure volume variation or the stroke volume variation. Accordingly, they will tell you how much fluid is given to this patient. This is separate topic. But even on CVP, you can assess it that how much fluid is given. But only one thing remember, don't give any concentrated glucose to a respiratory failure patient who is breathing spontaneously. Sepsis. Septic. Avoid cold until the capillary pores are normal. At the capillary level, due to sepsis, they are vasodilated. When they are vasodilated, their pore size becomes bigger. So the colloid solution molecule can pass and go into the interstitial compartment. Don't give any colloid solution till you are sure
that the capillary pores have come to its normal size. How do you find it out? After first 48 hours, never give any colloid solution if the patient blood pressure, if the patient's fluid deficiency is present. Keep them on vasopressors. Try to constrict the vessel and give them crystalloids. Other crystalloids, don't give them this colloid solution, otherwise the molecule will go outside. And after 48 hours, through the centrovenous catheter, you give a bolus of 200 ml and see how much CP has come up. The CP has come up, and within 5-10 minutes again CP goes down. It means the pores are still open. After 15-20 minutes, if the CP is gone up, you have given a bolus dose of coli, and CP has come up, and it stays more than 25 minutes. It means the pore has come to normal size. Now you can give a colloid solution. See, this is the test for it, that whether the pores have come to normal size or not. So always, first 48 hours in sepsis, don't give any colloid. Try to control the blood pressure or try to control the hemodynamics on vasopressors or electrolytes. ARDS.
The patients in ARDS go to acute respiratory distress syndrome, the adult respiratory distress syndrome,
different names are given. So again, because of sepsis, their pores are open. So we can take all that precaution. In addition to that, we do the progressive dehydration in this patient. So progressive dehydration means you take the person into negative balance while keeping the hemodynamics normal. Take the person into negative balance of 1 liter or 1.5 liter while keeping the blood volume normal. Because it is the blood volume which is very important for the delivery of oxygen and nutrition to the tissues. So you do not induce hypovolemia, but you take the person into negative while keeping the hemodynamics normal. This is called progressive
dehydration.
Only two conditions in which you
Do the progressive
dehydration. One is ARDS, and the other is pre-eclampsia and eclampsia. Progressive dehydration. That's how you can treat the patient. Burn patient. Again, with a burn, there is a opening of the pores. Again, you don't give any colloid in the beginning, at least 48 hours. Then you assess whether the pores have come to normal size or not. If the pores are coming to normal size, then you can give them
A colloid solution.
Otherwise, give them crystal.
Doesn't matter. Pores are open and the fluid will be going into the interstitial compartment.
And then once the pores are come back, then you can get the fluid back. And
Do the diuresis in those patients.
but
Once the colloid solution has gone out, it's very difficult to bring back all those big molecules.
they will start exerting its colloid activity in the
Interstitial compartment. Right. It's very important in the burn patient.
and in septic patient. No colloid till the capillary pores are normal. Colloids in acute kidney injury. The normal plan is, as the nephrologists say, previous loss plus 500 is called insensible loss. Insensible production and insensible loss, and the difference of that to add to that. Then you might have to give potassium supplement, and might have to give the calcium supplement.
Might have to give magnesium supplement, because this is a case of nephrologist. In acute liver failure,
Problems in acute liver failure is patient tends to go into hypoglycemia. There are so many reasons for it. That's a separate topic. They don't have a storehouse, and insulin is not being metabolized because acute liver, so insulin level goes up, and patient is taken into hypoglycemia, and there is no storage for the glycogen, and there is less glycogenolysis, that the patient goes into hypoglycemia.
low glucose, low sodium,
Patient goes into metabolic acidosis because of liver failure. Then,
fluid deficiency,
and if the patient is vomiting,
starts vomiting.
also, that you lose a lot of water also. So, these patients are hypotensive also. Why they are hypotensive? Because yesterday I mentioned renin-angiotensin system cannot compensate, cannot start, because angiotensinogen and globulin. All the proteins in the body, they are synthesized in the liver except gamma globulin. So alpha-2 immunoglobulin is not synthesized, so there is no place for the renal to be active on it. So it means the renal angiotensin system will not form. Angiotensin 1 and angiotensin 2 will not be formed.
Blood pressure goes down.
So that's one of the most important causes of hypotension is acute liver failure. You know, the renal angiotensin system do not take its proper effect. So,
Looking at all these things,
so it means we will have to give glucose to this patient, otherwise they will go into hypoglycemia. Then as sodium is low, we have to give saline. That's what we do. We give 10% glucose along with saline, 0.9% saline, no other fluids, no lactate. Because lactate is normally converted into bicarbonate in the liver. If liver is ineffective and it cannot convert it into bicarbonate,
it means the lactate will accumulate. It will cause lactic acidosis.
It will take into metabolic acidosis.
Acute liver failure.
Avoid extra lactate loss, as Rigolect said. 5% extra is a poor vessel filling. 10% should be given at least. Folate is a poor metabolite. Should not give any cola to these patients. Use of inotropes and vasopressor
depending on the hypotension. Okay? And cephalopathy. If they go into cephalopathy,
elevate the head
35 to 40 degree, avoid hypoxia, hypercarbia, hyperglycemia,
and if the bilirubin goes up 200 micromole, give them mannitol also, because we will have to flush the renal tubule, otherwise there will be obstruction of renal tubules and it goes into renal failure. Basically, they tend to go into hepatorenal syndrome also. Acute liver
use of amino acids, because our
gastroenterologist
they
use amino acids
also in the acute liver failure. Amino acids are
especially the branch chain amino acids. Branch chain amino acids are the same. If you look at the metabolism of branch chain amino acids, why would we give the branch chain amino acids? Because it will consume the ammonia which is produced by liver, by the liver failure, and the consume HFP, you have to give branch chain amino acids. And if you look at the cycle, for all reactions to take place, you need
energy.
So for provision of energy, you need glucose. So whenever you give amino acid in a liver failure patient, always give glucose with it, because you require energy to convert the ammonia
into urea.
But you give only amino acid, the patient's renal functions are normal. If the renal functions are not normal, the patient will have renal syndrome. Then if you give amino acid, it will produce urea.
The kidney will not be able to
wash it out. The patient goes into urine also. So you should not give any amino acid solution to a person if you got a hepatorenal syndrome. If the kidney is functioning normally, then give it, but along with it, give concentrated glucose also, because we need ATPs to during this whole urea cycle, right?
cardiac failure. You give fluid according to CVP, control the volume according to chemistry, you control the type of fluid also. See, it is just like simple thing. Put a CVP catheter in and see what is the pressure. Accordingly, you give them fluid, and then type of fluid again depending on the electrolyte concentration. Brain insult. Keep in negative balance. Every patient who has got a brain insult, we keep them in negative, 1 liter to 2 liter.
0% 9 saline is there because the saline is a solution. Now
you've got a saline 0.9%. How much is sodium in it? 154. And how much should be negative ion with it? 154 plus 154. So it's 308. This is the osmolality which is required for the brain edema to be reduced. So we keep the osmolality between 308 and 310. If you give, for example, rigolactate, how much is the sodium in the rigolactate? 164. And 164, कितनी होती है? 154. 154 तो उसमें होती है, इसमें होती है, कितनी होती है इसमें rigolactate में?
135. 134, 135 millimole is the sodium, and you double it, so it becomes to 68. So it is a hypotonic solution. So normal osmolarity is 285 to 95. So it comes out to be 134, 134 to 68. It is less. So if you give in brain insult, it will increase the edema. So this is not an ideal solution. So ideal solution is saline. If you give levodopa, it has got 64 only sodium. 64 plus 64, 128. It's very, very hypotonic. So it should never be given to any patient who has got brain insult. Right? Otherwise you will not be able to treat brain edema, rather you will enhance the brain edema. And avoid 5H का मतलब है hypoglycemia और hypoglycemia, hypoxia and hypoxia, not hypercarbia. So these 5 H's should be avoided. But in case of subretinal hemorrhage, if the patient has bled, then there is a vasoconstriction immediately after that. That's why if there is subretinal hemorrhage, try to find out if there is some aneurysm which is ruptured. And immediately after the rupture of the aneurysm, we go to constriction. To avoid this constriction, because if it remains for longer period, it will cause brain ischemia. To avoid that, you will have to do triple H therapy. Triple H therapy means you take the person into hypervolemia. You have hypervolemia and induce hypertension and induce hemodilution. All these three factors, hypertension, hypervolemia and hemodilution, will increase the blood flow. Even if the vessels are constricted. Why the vessel will go into constriction? Because if there is a rupture of aneurysm, due to rupture of aneurysm, there is a breach of capillary endothelium. Capillary endothelium produces nitric oxide. Nitric oxide is a vasodilator. When the capillary integrity is breached, there is no production of nitric oxide, so the vessel cannot remain dilated, so it will become constricted. Now, this is a separate topic, nitric oxide. So nitric oxide is a very important chemical which is secreted by the body. So triple H therapy is one of the ideal to be given. Right, thank you very much. This covers your fluid therapy. I've gone through very quickly because everything needs to be explained more and more. But just to give you the idea that if a person has got some common diseases like this, what type of fluid should be given, at what rate should be given, you should choose the proper fluid for the proper recovery of the patient. Thank you.